It's great to be here because I got something that's important to talk about. To me, it's critical to the future of private care dentistry. And that subject is complete care. Specifically, minimally invasive complete care that is based on health, wellness, and longevity. You know, dentistry is in an insurance-driven disease care situation. We're also being intimidated by the dehumanization of corporate dentistry. The model that many of us have to practice under is suppressive. It's manipulative. And you know what? It's non-sustainable. So many dentists are working harder and faster for less and less. It's a broken system. The answer, I believe, is not in seeking more patients to do single-tooth dentistry. The answer lies within one of the freedoms we still have, and that is to develop a health-centered relationships with patients that are already in our practice, that already love us and enjoy being there. The kind of dentistry that I'm going to show you is transformative. It's beyond insurance. It's not about what I'm going to do to you. Rather, it's about what I can do for you. So let's begin. The easiest way to get into this is to show the kind of complete care that I'm talking about. Here we see photographs of the same woman. Does anyone see a difference between these two pictures? Does she look more stressed to you on the left photograph? Do her eyes seem more open on the photograph on the right? This is complete care that addresses the entire chewing system. Her whole face has changed. It's totally let go. She's smiling without effort. Before, she's working at it. Her smile is more like a grimace. And yet, you know what? The actual amount of dentistry that was done on this case is very minimal. There were composite additions made in certain areas to teeth that had worn down because of dysfunction. And yet, the effect is the whole person. This case, done by a former student of mine and now a faculty member, Dr. Barry Hilligan from Portland, Michigan. Here's another case that I think speaks for itself in terms of the contrast. This case was done by a student, Dr. Mario Samaniega from Las Cruces, New Mexico. And this is Mario's daughter. It's a post-orthodontic case. He looked at this young woman every day, suffering from migraines every day. And we did this case together in level 3 in Albuquerque. And would you say she looks thinner to you? More alive? She's pain-free. The whole system has been treated. And yet it's minimally invasive in the fact that there's not one crown in this case. There's not one preparation. Everything was additive. And there was a fair amount of it. You know, who is complete care for? Well, it's first for people that you love. This is my youngest son. You can look at the forehead here. Do you see these wrinkles? What is that? That's the frontalis muscle. It's also called the corrugator. There's 1 day difference between these two pictures. And again, the entire face changed. And again, the dentistry was minimally invasive in that all you're looking at is composite additions. Additions to what was worn down. I always keep this case. It was done in 1992. And I keep it because people say, you know, how long does it take for these changes in the face to occur? And these changes are the same day. When I did this case, I didn't know what I had. 1992. She came in wearing her mago. We're going to do this case, so I told the staff, let's get some pictures. So she took the mago out, they took some photographs. And when we got done, they took some photographs. I didn't realize how powerful this treatment is because it affected her whole face. So what I'm suggesting in these last 4 cases, all these people suffered from a disharmony in the chewing system, specifically occlusion disease. They were each diagnosed, resolved, and treated. And I'd like to share with you more about what that is about. Gordon Christian said, the 3 major diseases we treat are caries, periodontal disease, and occlusion. Occlusion remains the most untreated disease in dentistry today. We probably treat caries too much, perio too little, and we don't even talk about occlusion. Dr. Lee said, tooth wear is rampant in America, affecting many even in their 2nd decade of life, and is a cardinal sign of occlusal disease. Dentistry today is too focused on bug control and not enough on force control. Bug control meaning control of bacteria that cause caries and cause gum disease. Treating and preventing wear and tear of the chewing system is an integral part of complete dental care. There is so much work to do in our existing practices that people need this help. We could never do it all, and we already have it. The chewing system is one system. We can't separate the teeth from the jaw joint or the muscles. The afferent signals are being sent by every part of our body to the brain. The periodontal ligament, the lips, the mucosa, the tongue, the airway. What we're discovering is imbalances in the airway and inadequacies is a huge factor in causing disharmony in the masticatory system. What about the TMJ, which is so vulnerable to wherever the teeth fit? Wherever the teeth fit is where the joint is going to go. And all of these things are related. It's really great when the messages to the brain are one of harmony and everything's okay. Then the efferent messages coming back can be the same. But we're depending on that efferent message to the muscles of mastication and also facial expression. So what I was showing you, those results are a special kind of complete care known as bioaesthetic dentistry. So what is it? Bioaesthetic dentistry is based on the study of optimal chewing systems of people of all ages. The commonalities observed from studying these great systems have sourced the discovery of the biologic principles that bioaesthetics is based on. These biologic principles apply universally to people of all ages and to all disciplines in dentistry. And before I continue, I have to acknowledge the founder of bioaesthetics, the late Dr. Robert Lee, who coined the phrase and defined it as the study or theory of the beauty of living things and their natural forms and functions. You see, Dr. Lee was a biologist before he was a dentist. He believed that nature got it right. And after studying health healthy systems. He figured out how the mouth works. No one had done that before. Amazing contribution. Tom and I first met him in a lecture in Eugene, Oregon, 1989. I'll tell you what, within a half an hour, my life as a dentist had changed forever. I like to say that he gave me the gift of sight, the ability to recognize health and then disease. It was right under my nose. I just didn't see it. He's the one that said, form is everything. And so his nickname, Dr. Form. And so what does form have to do with it? If you were going to invent a structure that would fly, and your job is to make an airplane wing, you're going to have to give the form to that structure that will promote flight. So in invention, form follows the function. But in biology, the form came first, and function always follows form. And what about biologic form? If you were an aspiring athlete, whether you're a woman or a man, and you want to be an Olympic athlete, would it make sense for you to study the physical attributes of the gold medal champion that you want to be? Isn't that done all the time? Why don't we do that in dentistry? Why don't we study gold medal occlusions? Well, if you want to know what one looks like, this is it. We could spend an hour on this picture alone. But just suffice it to say, look at the front teeth, the ones in the middle. Do you see they're long and large? Look at the ones next to them. Are they shorter and rounded? And what about the canine or eye teeth? Are they long and pointed? Guess what? It's always this way. Whether you're a Mr. or a Mrs., whether you're from China or Chile, it's always this way. Now, what about beauty? Is beauty in the eye of the beholder? Jorge Ayala is a Roth-trained orthodontist from Chile who's done work on facial proportions, geometric proportions, and came up with a schematic that if you had these proportions, you would be defined as beautiful. Let's see if that holds up. Here's a woman that I think is beautiful. And look how these geometric portions match her to a T. This is a patient of Dr. Dumont's. But she didn't always look that way. She used to be in horrible pain. Debilitating migraines. Horrible. And if you develop the gift of sight, you can look at that face and see tension. You can look closely to the muscles in the neck and you can see disharmony. Fortunately, she received complete system bioaesthetic care. And her whole face changed, her whole outlook on life changed, and she's pain-free. She has her life back. And yet, the amount of dentistry that was performed was still very conservative. We're looking at composite additions on these upper front teeth. So we can ask the question, is natural beauty and optimal function related? And what we say is they're inseparable. So here she is before treatment. Wear on teeth is the sign of occlusal disease, and the disease is abnormal function. Look at those front teeth. Could that a little bit of wear mean something? Yes, it can. Look at her smile, and look at it now. It's a huge difference as a result of bioaesthetics. If we were looking at, for 3 words that summed up the health benefits of bioaesthetic dentistry, just 3 little words, they would be lasting natural beauty. Why don't we know about this already? Why aren't we being taught this in dental school? What's up? Dentistry, unfortunately, is still being taught on a disease model. It's always been about what's wrong. Medicine is too. If you're not sick enough to give it a name or a disease, we can't help you. And what do we want to do? We want to get them out of pain. And so we do what we do to people to help them. And we get them to a certain sign here, regression to the mean, until they stop complaining and we think it's over. You know why? We don't have a health model. We've never studied what was right. There's a whole new world, and it's the world of optimal health. And so we need to stop and study optimal health. And to do that, we've got to take a closer look at nature. A large portion of your cortex, and my cortex, is devoted to the masticatory system. Why? It is vital to our survival. It's extremely important. In embryology, there are 3 primary germ layers. There's endoderm, there's mesoderm, and ectoderm. Enamel is way down here, and we come from ectoderm. Why is that important? Because the 3 branches that are our cousins, if you're Mr. Enamel, are the outer epithelium, the neural tube, and neural crest. These are highly innervated systems. We believe that enamel is calcified neurons. It's neural tissue. To prove a point, have you ever seen the ladies from Japan that can take a pearl and put it between their teeth, and by feeling it with their teeth tell you if it's a natural pearl or not? Have you ever seen that? It's an amazing, you know what, we should get that. Enamel is extremely sensitive. We also should appreciate that our teeth were predetermined at birth. The teeth are already formed before the jaw joint, before the muscles of mastication. The tooth form is there. And what's amazing is at birth, there are no erupted teeth. There's no jaw joint. How does the baby survive? By chewing with its face. The facial musculature and the infantile swallow, which is governed by the 7th nerve, is what keeps this infant alive. The brain doesn't forget that. That's how we started off. Then, as we witness the miracle of growth and development, when we see this young girl developing in 3 planes of space at the same time to achieve the form that she was destined to have, it's a miracle. And so we as dentists need to know, what does a gold medal occlusion look like when you're 5? Well, we think it looks like this. Something happens at age 6. When your permanent incisors get close, and then they touch, there's a neural communication there that stimulates the completion of development of the condyle and the masticatory musculature. You know what? We think that this central, the right one, is responsible for the surveillance of what's happening with the left jaw joint. Conversely with the other central. This is the ugly duckling stage. What does a 9-year-old look like with a great occlusion? Like this. There are 12 permanent teeth at this point. The 8 up front and the 4 in the back. And the 4 in the back are the first molars. Extremely important, because between the ages of 6 and 11, it's the first molar that's the guide tooth. It's the one that keeps us out of trouble. So, the question is, how sharp are natural teeth? Here's an 11-year-old. This is actually Barry Hilligan's son. And his teeth are this sharp. I'd say that's for real. There it is. So, going back to what I first showed you, these gold medal occlusions, it's always this way. The centrals are long and large. The next teeth are short and rounded. The eye teeth are long and pointed. Do you remember seeing a case like this when you were in dental school? I can tell you I don't. Because a case like this would rarely get to the clinic. There's nothing wrong. I have never had a class on what an ideal occlusion should look like. Never. Here's 18. Look at the centrals. It's the same, you guys. It's the same. This is Tom's youngest son. He's got a gold medal occlusion. I wonder if it came from his dad. Doctor, you had part to do with it. The centrals are long and large. The laterals are shorter and rounded. The eye teeth are long and pointed. Always. If the system is in balance and there's no wear. So do you think this 90-year-old lady is going to lose her teeth? Brent, you think so? Don't you think our Creator designed us with a dentition to last our entire life? Doesn't that just seem natural? I think so. It was Dr. Lee that first said, perhaps the best rule to follow in treating patients is to simulate the tooth relationships found in untreated, non-traumatic, long-lasting, natural dentitions. Dr. Lee. And you know what? The oldest one we've studied, 103. So, I mean, is there optimal biologic dental form and function? This is original research from Dr. Dumont. It's not only about photography. When you get a great mouth, you take impressions, take a centric bite, and here this case is mounted up on a jaw movement simulator. The centric latch is not engaged. The teeth fit together perfectly, and the incisal pin holds articulating paper. So what happens if you close the centric lock? Nothing. The paper stays the same. The teeth don't move. This mouth is naturally in centric relation. These are the kinds of systems that we've studied. And so we look and observe. We go through various test positions, and we see, gosh, when you put the front teeth together, they're the only teeth that touch. Everything else has space. When we go to one side, there's clearance. When we go to the other side, there's clearance. Is that significant? So you're doing a study. You write this down. This is what I'm observing. Dr. Lee, how long are teeth? How do you know? You measure them. So you can measure this great system, and in this case, his upper centrals are 12 millimeters. The lower centrals are 10. His overall vertical dimension is 18. And he has an overbite of 3.8. That's scientific fact. So you study mouths like this and put that all together, And you come up with commonalities that are universal in these great mouths. And this has sourced the development of the composite biologic model. This is not an impression of someone's teeth. This is a wax-up. And this is our touchstone. We can diagnose from this and treat towards it. So we can look at the biologic model, the composite on the right, and compare it with a real mouth. And you could look at both of these pictures, and can you see some commonalities? You can also say that, you know what, these teeth are kind of yellow. You know, maybe there is some wear here. Well, guess what? He's 93 years old. 93 years old. Do you think he's going to lose his teeth? Well, I can tell you he's not, because he died quite a few years ago. But he's walking around with a 12-millimeter central. So if we could create for our patients what Joe has in his mouth, we'd have a dentition for a lifetime. And that's what we've done in bioaesthetics. And the three principles that we discovered, actually Dr. Lee did, are these. Number one, the jaw is in the socket where it belongs. Every time we swallow and our teeth touch at the same time. Principle number one. Number two, the teeth are arranged in such a way that they have overbite that guide the jaw back to this happy place in the socket every time we chew and every time we swallow. And three, the teeth themselves have genetic form without wear, little to no wear. And when we look at genetic form, bow down to it. We're not going to do anything creative with genetic form. It's already been done. We're going to copy it, though. Exactly. So level 3, which is the minimally invasive class that we teach that could benefit so many patients, takes a mouth like this, but we make a systemic diagnosis, and then we're going to look at this mouth, and we need to compare it with something to help us decide what to do. And what are we going to compare it with? We're going to compare it with a gold medal occlusion. Now, besides being a B1 bleach shade and the world-class occlusion being a natural A2, if you could get by the color, significant difference between these two is that there's hardly any overbite, and here there's a lot. Is that significant? Absolutely. The other major difference is this. I want you to look at the angle of the canines, the lower canines. These are going like this. These are going straight up. Can you see that? And so our job is to right the ship minimally invasively, and you can look at this picture down below. This, folks, is this mouth. It's the same mouth. There has been composite additions to these teeth, and this is the result. You can't even see it. So here's what we do. We take a mouth like this. Even the lower incisors are all worn down. It may seem like nothing, but it is huge. And what we do is put back what's missing in wax. We teach our students and our technicians, how do we do that? It can be done. We put it back in wax, and then we have a way of transferring that wax up into the mouth in composite. So that we can take this case, and here she is, the same mouth you were looking at. Most people that don't have the eye for health, as I didn't, will look at this and say, has a beautiful smile, a beautiful young lady. What? She doesn't need any dentistry. And here she is after bioaesthetic treatment. Here she's having migraines. Here she's having symptoms. Her teeth are wearing out. minimally invasive dentistry put these tips back and created this, which is health. Do you think that's a good case? Or do you think it's over-treatment? So, level 3, I think it's the greatest course we teach. It's minimally invasive. It gives our patients the best of both worlds, aesthetics and function. There's a lot being said about evidence-based dentistry. It's important. Is what you do have any validity? You know, is it in the literature? What is your concept of how the human masticatory system works? Just going to say, like to you, Mike, how does the mouth work? You tell me, and based on what? Let me tell you how the mouth doesn't work. We were taught incorrectly in dental school by starting off with an articulator. On the articulator, what moves? The upper jaw, not the lower jaw. We got everything mixed up. We don't chew down, folks, we chew up. Let me show you, let me have you feel what disclusion feels like. Disclusion is an articulator term. It does not happen in nature. I'm going to prove it to you. Have your teeth together. Imagine you've got really long teeth and they're just locked in. Now I want you to try to unlock it. How do you unlock it?
Straight down.
What'd you do, Mark?
Straight down.
You opened your mouth.
Yeah.
How hard was that?
Awful hard if it's locked in.
Now do this. Put your teeth together and slide them out, slide out forward. How does that feel? Feels terrible, doesn't it? Do you know when we do that? When the dentist tells us to. People don't do that. Now here's the other one. Everyone talks about cuspid rise. That's an articulator term. It doesn't happen in nature. Close your teeth and slide out to the side. Slide out there. How does that feel? We don't do that. So much of the literature that we read is wrong. It's based on a prosthetic model that is not alive. You know, we're showing you these optimal occlusions. Isn't that proof of something? Isn't that evidence? This optical model we're talking about is not a concept, it's a fact. You can find it in your own office. Living evidence. And who are we anyway? We're a nonprofit educational institution that teaches the biology and clinical practice of bioaesthetic dentistry to dentists and dental technicians. Our sole purpose is to give you professional fulfillment as a dentist, to be the best that you can be, so that you can be the best you can be for your patient. That is our sole reason for being around. So the name of our first class is Biologic Diagnosis. And I love this picture because it's a metaphor of what we do. This is an assistant of mine from years ago. She's in Australia and she's doing a bungee jump. And what we like to say at OBI, we all get wet. We all do it all together. Our first session is all about diagnosis, and so we get the whole team. Get everyone together. And then we learn how to do these things on each other. It's wonderful because you can get immediate feedback. I like the way Mark does it, but Jim, the way he does it, it hurts. So hands-on learning is, you cannot learn this without being hands-on. A lecture won't do it. We learn how to take a centric bite. The best way to do it is to have it done on you, and then you do it on someone else, and then on someone else, and get the feedback. We learn how to use this instrumentation so we can mount a case up. When you get your hands on it, you can understand it. It's not complex. We learn how to mount casts. And during this first 2-day session, we mount casts on all the students. And then we can do and do a preliminary diagnosis for everyone's mouth that wants it. I mean, that's worth the price of admission just to have the diagnostic done. So it's all about diagnosis. A diagnosis is not a checkup. This is not the kind of dentistry when you look in someone's mouth and say, oh, hey, Bob, you need 8 veneers, plus you need a root canal there and an implant there, and we'll get you started. This has not got that kind of dentistry. The first thing we want to find out is what's happening. And the most important thing is why it's happening, because if we can figure that out, then we can determine, are there viable options that Mary can consider for the future of her health? We got to figure that out. Dentistry and insurance does not pay for diagnosis. But guess what? Patients will pay for diagnosis because this is transformative dentistry. This is not usual and customary. This is not governed by insurance. The last thing we do is how can we make it better? So at OBI, we believe that the jaw joints need to be stabilized prior to a diagnosis, and this separates us from everyone else. We believe in stable condylar position, and where is that? That's where the jaw's in the socket, where it belongs, anatomically and functionally, and with the correct muscle pull. And it's an orthopedically stable position, and there's lots of research to support that. And the way we do this, and this is session 2, level 2, we learn how to make an orthotic, and we make it on each other. And it's amazing what happens. The principle of the MAGO is to create a class 3 lever system whereby condyles that are displaced out of the socket are given the freedom to go back home where they want to go. The alignment of this system is amazing to see what happens, and I'm going to show you it. Here's what a MAGO looks like that's been adjusted correctly. It's a diagnostic tool to align the system by seating the condyles into the fossa, preparation for final diagnosis. This is, I think, worth its weight in gold. I know of no other splint that does this. Here is a patient. Here's the same patient 25 minutes later with the MAGO in his mouth. Do you see a difference in the eyes? Do you see more energy coming here? Do you see a resolution of neuromuscular release? And how long did it take to happen? Minutes. We're dealing with the facial nerve. It's electric. This lady is from Belgium. When she saw this picture, the same day we put the MAGO in, she couldn't believe it. And she said, you know what? It's been 20 years since my eyes looked like that. People used to comment on the love in my eyes, and they haven't for years. She said, I want this. Transformative. It's beyond insurance. If you want something, you're going to figure out a way to do it. Isn't that kind of an amazing result? Because you're doing more than one thing. You're getting the system aligned. You're replacing lost face height, which repairs this mid-face collapse. So you're ending up with a facelift and neuromuscular release, and the 7th nerve relaxes. Fast. I think the ladies would like this. Here's a lady that has the MAGO in place. Let's look at her lips before MAGO and after. In fact, let's measure it. There's a 20% increase in lip volume. People are getting their lips injected. And what they really need is to have their teeth fixed, or have a mago put in because the lip is there. It's just rolled in and you can't see it. Here it is from the sagittal view, and it shows the same thing. Same person, same lips. This is a case from last month, Rogue Valley. What to do? Periodontal care and a mago. That's what to do. Sometimes with the mago, depending on the case, sometimes we'll add some teeth to it, artificial plastic teeth, to help. You can see before and after the mago. But here's what I want you to see. This is the same day. There he is. Do you see more energy coming out of his eyes? From the side. Opening him back up, restoring his face height. And this is the same day the mago was put in. That's how he looks with the mago in. Now, is he likely to wear this mago long enough to get stable? You can't get it away from him. Because we started here, we went to there, and is he motivated to go on with treatment? He is. And here's something else. And you don't have to be a dentist to see this, but this is radical. We're looking at a cone beam CT of the same patient before mago and after mago. Look at the neck, the cervical vertebrae on the picture on the left. Do you see the curvature in that neck? Do you see the curvature gone in this picture? So when you align the system, good things happen. It's amazing, and I think that the mago is probably the best thing that we do. And to have it done to yourself, and then to be able to do it on your classmate, and then do it on your patient, and you'll be taking the same pictures that I am, it's hallelujah. Level 3 is where the minimally invasive, this is where we work on a patient from our own office. Everyone does a case. There is no working on mannequins in OBI. We all do it. This is a case. Dr. Jennifer Garza, Colorado Springs. She's actually an orthodontist. This is her patient for class. What's wrong with the patient? Chronic headaches, neck and shoulder pain, facial muscle pain, clicking and popping of the joints, joint pain. This is the look of pain. She's miserable. She's a mom. She's having difficulty holding it all together. You go everywhere for treatment and you get put on medication because no one knows what's wrong with you. Fortunately, she got a diagnosis from Jennifer. We can look at her teeth. And you don't have to be a dentist to look at this canine and see where the gum is and think, God, is that right? You don't have to be a dentist to, what's happening to this gum? We take a cone beam CT and what do we find? The condyle on the left side is flattening. So there's real problems in this chewing system. And what we do first is put in a mago to get stable, to find a diagnosis. But the side benefit of that is she's pain-free within 2 days. There's 1 week difference between these two pictures. This is a grimace. This is a smile. This is a life of pain. And you can tell by the eyes. We started looking at eyes about maybe 18 years ago, 19 years ago. And that's really all you have to look at. The eyes are the window of the soul. So we affect eyes by fixing the teeth. And the reason is the facial nerve. The seventh cranial nerve is the nerve that innervates all these tiny muscles of facial expression. These are tiny muscles that are weak. They originate and insert on soft tissue. And because of the infantile swallow, when we were all a baby, we were using our face to chew with. And when this system gets in imbalance, your face is called upon to help out. And that's why these expressions look so grimaced, and also why they look so relaxed when we get it fixed. For this patient, it took 3 months to get totally stable, but she was symptom-free right away. After she's stable, then we do our instrumentation. We learn how to do this in class. We all do this together. In her case, we're trying to move the front teeth together so they touch. They won't touch. They can't touch because the back teeth are in the way. And when the back teeth are in the way, the condyle is distracted out of the socket. No wonder she's having headaches. Everywhere she goes, there's a landmine. This is a mouth that is not working. We can get it to work again. You know why? Because we can wax it back, what's wrong, and we have a guide that'll never let us down. So bioaesthetics is destination dentistry. We know where we're going. We've been there before. And so this is the wax up. Now, OBI, we have methods, incredible methods, of getting that wax up into the mouth using injection molding. It's what we teach. It's what all of our students do. And we're getting incredible results. Here is how she looked when the mago was being worn. That's where the mandible ended up, and here she is, completed. This was all done with composite. There's no crowns. Just replacing what was worn off. How long does composite last if you put it on the edge of a tooth? If you're not eccentric, it won't last the rest of the day. Yeah. But if you are in stable counter position, it lasts. Look at the lips. Restoring length to worn anteriors and cusps of posterior teeth will restore symmetry and beauty to the lips and facial expression. Adding these little tips to this makes the lips come out and be beautiful, just like they did for this lady. Before treatment, she's trying to smile. That's the best she can do. After treatment, a smile is just natural. This is the kind of dentistry that patients start talking about. This is the kind of dentistry that gets people's attention. I'd like to share with you this case. Is this a gold medal occlusion? This case was done by a faculty member, student of mine, now he's faculty, Dr. James McFarland. Are the centrals long and large? Are all the front teeth the same length? Is this tooth wear? Is this occlusal disease? Yes. Does she have a disharmony in her chewing system? Yes. What is she going to look like when she's 32? So, first thing, align the system. Now, this is after the mago has been worn. Now, this is how the teeth fit together. She has an anterior open bite. How come? Because the way it was before, when her teeth were all worn down, the jaw was distracted out of the socket. That's what caused the tooth to wear. Now with the jaw back in the socket and the whole system happy, no pain, muscles are happy, now we've got to do something to the teeth. And I think this illustrates it. Before treatment, that's how the bite was, all worn down. taking a centric bite on day 1. This is what it looks like. But this is not stable yet. After the imago, this is the truth. This is the reality that will stay. This will allow longevity of treatment. And so, in this case, here's how the teeth looked like after the imago, and here's how they look like after treatment. In this case, the patient wanted porcelain. This is not as minimally invasive as using composite only. What was done were very conservative preparations. Here's how it looks after it was completed. Could have also been done with composite. Here she is after. Looks very natural to me. There she is. Her whole system now is restored. And I just think it's a great result. The one thing about our training is this. We have the highest student-teacher ratio in dentistry. It's 4-to-1. We have 1 instructor for every 4 students. No one else is even close. We offer hands-on training. Everybody gets wet. We end up with long-term mentorships and relationships that last a lifetime. We learn how to put this form on together. And we have camaraderie that lasts a lifetime. Now, there is one more level that we teach, and that is level 4. And these are for cases that are so, dentistry has failed this group of patients to the point where we've really got some work to do. And we're talking about bioaesthetic rejuvenation. Yeah, this is way out of control, wouldn't you say? What do you do with a mouth like this? Well, fortunately we have this, the optimal model, so that we can take a mouth like this. We don't want that. We want a mouth that looks like this. And so we learn how to wax that. This takes more than an hour to do. We learn how to do that so that we don't want this mouth because we think that this mouth used to look like that mouth. And in some cases, guys, the teeth are worn down so much we have no choice. In this case, the rejuvenation was done with 28 crowns. Those are crowns. Now, in the last 4 years, we've done more and more level 4 cases with all composite too. So there are more conservative options today in level 4 than ever before, but it's level 4. One of our students from Colorado, and people look at that result and say that the patient looks younger. Do you think so? This is my lady from Belgium. We had to do implants, lots of stuff. This is a student from Pennsylvania. Did a beautiful job on this case. Maria Longo is a dentist from Boston. I want to show this. In 1995, this lady came to see me. She had crowns on all of her teeth except the lower front ones. Around every margin, my Explorer went under the crown. Literally, there was decay around every tooth. So in 1995, I rebuilt her by putting crowns on all of her teeth, but I did it bioaesthetically and treated the whole face. The only thing I did different was I added, see this? We did a graft here. And here is that same mouth 10 years later. Looks the same. But here's what's important. Here she is in 1995. Look at her eyes. Look at the way her head is tilted. Look at her neck. Here she is 10 years later. Most people truly feel she looks younger. She's not with us anymore. I'm going to end with this case. Dr. Mark Weber is a student from Louisville, Kentucky. Here's this lady smiling. Would you say that she has wear on her teeth? I'm just going to show you the before and after. Here she is, totally overclosed. The bone is built up with exostosis all over the place. There's so much compressive force. Here it is restored. In this case, we had to do crown lengthening surgery on all the front teeth, even in the bicuspids. Those how short her teeth were, 6 millimeter upper teeth. There they are restored. Lower incisors, 3 millimeters tall and restored. I think this slide kind of says it all. You can see she was open 7 millimeters. 7 millimeters. And in her case, all the back teeth were already crowned. So they were just recrowned, given the right form. This form is no good, you guys. It's flat. This is genetic. So we say we get the best of both worlds. I think that's a tremendous result. And so I like this. Here she is at 9. Next thing she does, she goes to the orthodontist. At 16, she has significant tooth wear, but her teeth are straight. At 22, she has more tooth wear, doesn't smile much. Doesn't smile, she's more reserved. At 54, there's obvious pain in her face trying to smile. Doesn't feel good, it's tight. And here she is at 55, rejuvenated. So that's why we say bioaesthetics is age-reversing dentistry. To take someone like this, transform their life. Yeah, people want this. So I want to thank you for listening to me today. And I want to just ask a question. Can you see a difference between these two pictures? If you can see that difference, then our time today was worthwhile. Because once you've seen it, you can't put it out of your mind. And you're going to see people every day that could benefit from this. The mission of our foundation is to promote the health benefits of bioaesthetic dentistry worldwide through education, research, and service to the profession of the dentistry and public. There's that natural smile. And I want to thank you very much for your attention.